Welcome, everyone. Happy to see everybody here again for our monthly webinar. We have a very special treat today with many points of data and indicators. I'll just ask if everybody coming in could open the chat box, click into everyone, and then let us know who you are and where you're joining us from. This is always a special treat. Great. I'm actually in a screen mode view. There we are. I was looking for this. Amber, Lynn from Sarnia, Brian from Sudbury. Thanks everyone for joining us today. Ganesh from SE Health, Ganesh. Wendy from Hamilton, Wendy Cherry, nice to see you again. Omar, and I missed where he's from. It's already going so quickly by here. Jagger Smith, nice to see you, Jagger. Dean Valentine, happy to have you back here with us, joining us. Again, everybody, thank you very much for joining us today. I think we're going to have a very interesting opportunity to share with you some of the data that we've been sending out and are making available to all of the Ontario Health teams. I continue to type into the chat, please let us know. Make sure that you click to everyone and not to host and panelists so that everyone can know where you are. My name is Walter Wochus, and I'm the Principal Investigator for the Health System Performance Network. Very pleased to join with you today. I work at the University of Toronto, and I'd like to acknowledge that the lands that the University of Toronto operates on here on the St. George campus for thousands of years was the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, the meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. It is my very great pleasure, and I'm always appreciative of the land. As much as we have changed it from its original landscape, I like to try and then figure out kind of as it used to be when it was often pathways. Okay, just to join in and welcome everybody. We'd like to know if you have joined us for an HSPN webinar previously. We have a lot of people online with us today, so I'm very interested to see how many newcomers we have. I think we might have a few newcomers with us. So have you joined us before? Just please pop into the chat if they've participated previously or whether this is your introduction to HSPN. Okay, and slowing down now, so we can end the poll and post that result. And amazingly, we have about 70% of people are back again. That's not amazingly, but for 30% of you, this is the first time you're joining us. So there are probably about 40 webinars now in the past that you can catch up on. They're all posted, linked to our website. And there's a lot of information on health system performance, Ontario Health teams, examples from Ontario Health teams, and other work that has been shared through this monthly webinar series. So thank you very much. And we're going to have a great event today. We're actually keeping this pretty much to ourselves. Myself, I'll be doing a lot of the talking today for a rare, I don't know if it's a curse on you or an opportunity, but also be engaging a lot in the chat. And with me today, I also have Vijay Kunam, who is a research associate with the Health System Performance Network, and Vijay's been working extremely hard in the background, putting together a lot of the materials that you are receiving and that I'll be presenting today. But Vijay does not work alone. We have quite a few people that have been working to support the Ontario Health Team evaluation, both through these indicators, as well as through our developmental evaluation that you've seen. And currently we're doing some work with the leading projects, and we're also going to have some work on how we report, and you'll see we're gaining some feedback today. Dr. Victor Rentes is a postdoctoral fellow here studying with us on how we provide information to make it useful and meaningful for decision making. So thank you to all. Tricia and Nusret are here helping with the webinar as well. Okay, I have one other poll that I'd like to share with you today. And so it is, whether you have used our indicator reports. So if we could put this poll up, wanting to know whether you are new and haven't received them. So that's going to be some people. Some people who have received them, but they just aren't sure. You aren't sure how to use them. And then there might be some active use of the HSPN indicators, prioritizing areas for improvement, as well as comparing yourselves with other OHTs. It's something we're going to start doing a little bit more of as we look ahead into the future. And if there are other ways that you've done it, please let us know in the chat. So I'm also watching the chat here to see if there are other uses that you have had for our indicator reports. And we've been doing this since 2021. So this is our coming into our third or fourth year of providing indicator reports. We had some baseline indicators at the very early days. Then we've had some special populations. We released some diabetes. We did a round with the CQIPs. And also now we have the new ones that are coming out. We've shared them out with each of the OHT leads. We are going to be posting, and I'll cover that a little bit later, onto our website as well. And we're going to be organizing so that all teams reports will be available on our website. Okay, we could show this up now, the results out, and I'm really, really pleased that almost 40%, 34% actually, have been using them to prioritize for improvement. We don't have anybody who's been using it to compare yourself with other OHTs. So this is going to be a new aspect and a new dimension that we're going to start encouraging teams to be able to do. And then about a quarter of people are really looking forward to this webinar because they're not sure how to use the indicators. And then a good number of people are going to be brand new to this. So welcome to you. No, two items are the same. No, one was for making improvement, and the other was, maybe I misread that. I'm sorry if that happened. We're going to kick off and go into this right now. Oh, that option was omitted from the poll. It's funny how it popped up as a result. Oh, it might have been off the bottom on the screen too. That's an option. Anyways, we have that feedback, and you can let us know if you're comparing to other OHTs and we in the chat, and we're going to do more of that. In fact, the first thing we're going to talk about here is how you as an OHT, each of the OHTs compare to others, and our provincial reports in the past have focused a little bit on this or provided the information, and we are going to give you a little bit of a preview. These are data that don't actually exist at the province because they're about relative rankings of the Ontario health teams. And so I'm going to have VJ. VJ could come on here, and look forward to VJ being able to kind of share this through. And VJ, you can just let me know. I'll start you off on the first slide, and let me know when to change.
Awesome. Thank you so much, Walter. Hi, everyone. My name is VJ. As Walter mentioned, I'm a research associate here at HSPN. So I'm just going to spend a few minutes talking about, how we've reported on some of these indicators and go into a little bit of detail on how to interpret some of the graphs that you have been sent in your PowerPoint presentations. So each of the 53 OHTs, they have received a PowerPoint presentation which presents their OHT results. And within that presentation, we've actually included a little bit of sample interpretations that we hope you find very useful when you're looking at your data. And each OHT also would have gotten 3 different Excel spreadsheets, which contain their own OHT's raw data for 20 different indicators, and we've done it stratified by 3 meaningful subgroups. So we've done it by Chi-High population grouping, by BC matrix system, and by primary care model. Next slide. So I'm just going to spend a little bit of time walking you through a few components of the PowerPoint presentation that each OHT received. So there are 2 sections for these reports. The part 1, the first section, provides your OHT's ranking, and it's being compared to all other 52 OHTs on 10 overall improvement indicators, as well as 5 improvement indicators for 3 common target populations. So we focused on mental health, addiction population, the frail and older adults population, as well as end of life population. And as Walter mentioned before, this is not available for the provincial report because, again, it's for OHTs that are being ranked against each other. And the second section of the report that Walter will focus on provides your OHT results for 12 indicators stratified by 4 different useful subgroups. So we've done these 12 indicators by material deprivation, primary care model, high population health grouper, as well as BC Health System Matrix. And the 12 indicators that HSPN chose to visually represent was just identified as being the most important to OHTs at this time. Next slide. So I'm just going to focus on the first part of the PowerPoint presentations that we've gotten. So these are just a list of improvement indicators that we looked at when we were ranking all of the OHTs against each other. And you can see there's 4 major headings or subgroups. The first one is we have 10 overall total population improvement indicators. And we look at things like premature mortality, ALC days, ACSC hospitalizations. And then moving on to mental health and addictions care indicators, we look at things like the number of patients that had frequent, so more than 4 ED visits for MHA, as well as repeat ED visits for mental health as well. And then for older and frail adults, we again have 5 improvement indicators. We look at falls, that ED visits that were, related to falls, as well as caregiver distress. And lastly, for palliative and end-of-life care, we look at things like deaths in hospital and ED visits in the last 30 days of life. Next slide. So we did use spider diagrams to help rank each OHTs across all these various indicators for both 2021, 2022, and 2022, 2023. So you'll see a sample of these spider diagrams in the upcoming slides, but typically the light gray lines, they kind of look like a spider web. They highlight the actual ranks, where closest to the center indicates the best rank among all OHTs. And then data points that are furthest from the center, they indicate the worst rank in comparison to the other OHTs. Each indicator is oriented so that the best performance is always closest to the center, regardless of whether the best is represented by like a very high absolute score or a very low absolute score. So we're always trying to get to our point to the closest to the center. And one thing I really did want to highlight is that spider diagrams measure performance relative to other OHTs for each year. So your OHT could end up in a situation, for instance, where they could have performed better in 2022, 2023 compared to the previous year. But if on average, all of the other OHTs also performed better in that specific indicator, your point on your spider diagram could actually be further away from the center. And it looks like you've done, a little bit worse in the next year when that's just the relative score, whereas your absolute score could have been higher. So in general, when it comes to spider diagram interpretations, we're trying to be small, we're trying to be close to the center, and on target is better. Next slide. So we're just going to go through a few examples of spider diagrams that actually represent, actual OHT spider diagrams. So for here, we have a spider diagram that's looking at this particular OHT's performance for total population indicators. And as mentioned, we have that light gray web that indicates the ranks. The light green points represent the OHT's performance for 2021 and 2022. And the darker green represents the OHT's performance for 2022 and 2023. So you can see here, this particular OHT seems to have some issues with ACSC hospitalization, a few issues for avoidable ED visits as well, and slightly less concerning issues for continuity of care. Particularly if you look at ACSC hospitalization, this OHTs have ranked lower compared to the other OHTs in 2022, 2023, compared to the previous year. So you can kind of see the dark green is a little bit further out compared to the light green. Whereas this OHT seemed to have ranked very similar for avoidable ED visits. And then for continuity of care, you can see this OHT has ranked slightly higher than the other OHTs. compared to the previous year. So overall, when this OHT is kind of looking at this spider diagram, they should absolutely look at other population-specific reports for additional ideas, but definitely something that they could focus on is ACSC hospitalization. Next slide. So this is a sample spider diagram for our mental health indicators. As you see, we have 5 of them. And starting off with the top center, the first contact in ED for MHA, this OHT seems to be doing fairly okay, and the ranking is quite consistent for both years without really much change. Alternatively, when you look at the frequent ED visits and repeat ED visits, there's a little bit of a flag that this OHT ranks fairly lower, and as the point is quite far from the center. And another thing to note is they've ranked lower compared to the other OHTs in 2022, 2023 compared to the previous year. Next slide. Moving on to how the spider diagrams look for feral and older adults. Again, we have 5 different indicators for this. And the one I'm going to focus on for this specific OHT is the fall-related ED visits. You could see that this OHT performed better than most OHTs for this fall-related ED visits, and they've been ranking quite high consistently for both years as well, as the point is very, very, very close to the center. Next slide. And this is just another example of another spider diagram for end-of-life indicators. Next slide. And I just wanted to end off by saying, the spider diagrams really look very different. And these are just different examples of how much they can vary from OHT to OHT. But if you want to take a look overall as how an OHT is doing, you want to ideally aim for a very small web. So if we're going to take a look at this, for example, if you want to look at the first diagram, the one on your top left, you could see it's quite large. They rank last for some indicators such as virtual visits. Alternatively, as an OHT, what you ideally want to aim for is kind of something like the middle bottom diagram, where the points, yeah, we are jealous of the middle ones. The bottom diagram where the points are very close to the center. The actual diagram is quite small and it's on target. This is just a reflection of that, they're ranking consistently high for a lot of these indicators. And that was just a brief introduction into the spider diagrams as well as how to interpret them. I'm going to now hand it over to Walter to talk about part 2 of the report.
Yeah, thank you so much. And there are a couple of questions coming up in the chat. So let me take a couple of these now, and we'll come back if there are other questions about using the charts a bit later. So there are a couple hoping we'll be sharing the slides after. Yes, we do post after all the webinars, the full slides and the video of the webinar will be posted, easily accessible. And the provincial PowerPoints is also being posted today, along with provincial results for the Excel files that you were sent. If you haven't received, please do send us a message. I saw 1 or 2 people. We'll make sure that you get them today. We had aimed to send them all out already, so if you haven't received them, let us know. Pretty soon they'll all be posted as well. There was a question about 2 lines within these graphs. They are different fiscal years. So it's the 21-22 fiscal year and then the 2022 to 23. So the data is current up to last March. And those are the 2 lines, that's why. And they're coded at the bottom of each of the graphs. The identifying the variables that are being measured. So the specifics of the indicators, there are 2 places. One, the decks that you've received provide definitions. We also have a technical report that's available online, and we're producing another specific technical report around these 12 indicators with a little bit further on the explanations of how to interpret them. That is also coming your way. But the decks themselves that we've shared out provide interpretations of the results and some of the specific indicators. And if I see some people ready, and please send me, let us know which OHT you're from. And again, they'll be posted online. I think our target date for that is February 15th, once we've had a chance to converse with each and every one of the OHTs. So they will be posted. It will be obvious. It'll be in our reports area of our website. We'll send out, as soon as they're posted online, we will send out a link to everyone who's attended today, as well as our broad list of invitees. You mentioned comparing between OHTs. Is that data on these diagrams? Well, you could compare these diagrams, but we do have league tables that we'll be putting out. VJ is working on a report that provides all of the OHT results. So that is analogous to the reports that we produced in 2021, where you can look at all the OHTs up. And we are also building, it's not the fanciest online tool, but it's a little bit of an online tool where you can create at least bar graphs and charts, and you can pick OHTs to compare your results to on all 27 indicators that we have available for the teams. Conversing at an OHT level, you can talk to either us around interpretation of the data or RISE coaches around how to use it in your practices. We are setting up, we will be over the course of the month of February, setting up individual meetings with every one of the OHTs to review the data and make sure that you understand how to interpret these results. So I am maybe going to come back to some of the questions after and talk about how did we pick 12 indicators to focus on. So I think this is of use to people to know, as we've produced Excel data sheets that have 27 indicators, and we thought that's like going to be too much. And so we did some field work on collecting the 12 indicators. So here is what we did. And I'm just going to share this around now. So we distributed surveys to an OHT representative. We have an OHT evaluation contact, and we wrote to all of them and said, who is the best person to provide input on the data that we are sending out? And so that might have been the evaluation lead. In some cases, it was somebody else within the team. There were 56 OHTs invited, 42 responded, 75% response rate. Most of the respondents held positions as executive directors or leaders in analysis or population health. And the OHTs were asked a little bit around how we had provided the data before and if they wanted something similar or different. And then we asked them to rank the importance. So we forced, and everybody didn't like doing this. In fact, I think we had one team refuse to do this, is to rank the priority of the indicators in order for us to be able to focus in on those things that are most important to the Ontario Health teams themselves. So this is one of the questions we asked. Do you think it'd be better to have a report that provides a full set of indicators for one of the existing sets? So go in and say, frail older adults, mental health, 5 indicators, overall indicators, CQIP only, and or provide a report that includes a limited number of indicators. And overwhelmingly, so 65% of the respondents said that we should provide a report that includes a limited number of indicators from each of the above, that would best suit the priorities. So here are some of the other comments that people wrote in. We had 3 open-ended text boxes for people to add in commentary. And just to let you know, is it possible to have a report for each of those 5 reports? As OHTs continue to shift toward population health management, we have expanded from our first priority to include all 3 available. So that led us to at least include those spider diagrams for all of the areas of improvement from the HSPN indicators. So thank you. I also appreciate that this is people hungry and using the data, and I treat this as a compliment to our work. And the next one is around that as a starting point of how people are performing and where we might need to focus on for those priority populations. So that's our intent here. And our intent today is to take, Q&A over how to use the reports, and then we will spend an hour with each of the teams talking about your own individual data. Today, we're mostly producing or sharing out aggregate or representative data and not specific to your individual OHT. You have that report, and we'll make sure that the right people have it. The reports provide added value over the Excel files, as not everyone can analyze large quantities. So we really took that to heart. We do provide all of the detailed data in the Excel files, but again, providing these PowerPoints allows you to have data in a way that you can just translate and use across your team. And we're going to help with interpreting the data along the way. So here was the one where, an example, you saw it earlier, likely selecting the last option. 65% of the people did respondents did say that this was their preference, a report with a limited number of indicators. And some guidance on the types of additional information that could be analyzed using the Excel files might help OHTs know what's available. So we'll do a little bit of that coaching one-on-one. I will also be creating a video online that leads people through the Excel file so you know where to find things, because every indicator out of that full set that VJ had put up originally, the 27 indicators, is available in there according to stratifications. And here's the final piece. We got this feedback from a number. Again, condensed slides being extremely helpful. For future reference, is there a central location where the data files are stored that can be accessed by all OHTs? So we have found this, and already in the chat, different people participating in the OHTs are like, well, I didn't get it. Well, we did send them out to each OHT, so it's not getting out to everybody that it should. We've heard a lot from the RISE coaches that this is very much true. They're not always circulated broadly. And so we've been letting everybody know as we share out these reports that we are also posting them online. And we're just going to let you sit with them for a couple of weeks. And on February 15th, it'll be our intention to have everything available online. You'll be able to access them from our HSPN website, our indicator reports page. There will be a tab that says OHT specific reports. And from there, you'll be able to find all of them. And I think it's our intention over time is to load up everything that we've done at the individual OHT level into that space. So what are some of the results of the top priority indicators? These are shown ranked. We had a 10-point ranking from most important to least important. Most important is shown in the bright green on the far left. So we really looked at what proportion of people said this was the most or second most important. Looked a little bit at the third, but mostly we made the decision based on that. And so you see here, if we drew a line somewhere around 25% of the indicators beating more than 25% being the top two priorities, you see ED visits best managed elsewhere, continuity of care, and ambulatory care sensitive hospitalizations. I'll say I was disappointed that cost per month alive didn't make it to the top of the list. I'm a health economist for those people who weren't aware. But I appreciate that these are areas that are somewhat looking upstream and towards a more integrated and population health approach, which is quite helpful, I think, for Ontario health teams. It's not just specifically within an organization such as a hospital. They do relate to hospital use, but I think the way to help solve these problems is through strong partnership with community. So I was pleased to see these ones. From the mental health, we again had high frequency and repeat visits being suggested. Within the older adults, only one really made it up into that top range, being repeat fall-related visits among those identified as frail. The other ones, not to say that this isn't an important area, but it wasn't a common area of importance across all OHTs. So everyone will have their own indicator result for all of the frail older adult indicators in that spider diagram. But in all of the different stratifications, we focused on those ones that were most common across all teams, and that's for our provincial work, and then also for your own team's work. And then for the end of life, we had palliative visits in the last 90 days of life and ED visits in the last 30 days of life. Finally, from the CQIP indicator set, ALC days, PAP test, and up-to-date mammograms, and the rate of ED visits as a first point of contact was actually included from the mental health one and here. So that is an indicator that is included in the reports. So here are the indicators, and you see where they came from now, the top chosen ones: ED visits best managed elsewhere, ACSC hospitalizations, physician continuity of care, 3 in the mental health area, 3 from the CQIP area that are not reported elsewhere, 1 from older adults, and 2 from palliative and end of life. So that's where you said we should land. These are the specific definitions, not the technical definitions. So let me come around to opening up the chat. I see there were a few options, and I am going to temporarily bring down the share so I can have a better view of the chat. So let's open it up. I see some other comments kind of coming in here. What's the ultimate goal? Where will good performers be mentors to less good performers? I think that that's going to be part of the learning here. I think our ultimate goal is to have an assessment and understanding of how well you're performing within your OHT, how things are changing over time, and to give you an idea of some of the indicators when you're making change ideas. You may not be making the move at the entire attributed population level yet. But within your initiatives, think about how do they relate to the big dot high priority indicators of importance to you. So are there things that you are doing in the community that will help keep people better managed for their chronic conditions, such as COPD and CHF in the community, so they are not ending up in the hospital? Similarly, being able to manage and provide options for individuals so they don't end up in the emergency department for reasons that are not needed. Certainly, we're still going to be needing and using the emergency departments, but we're just trying to, I think, focus on those areas that people with alternate good access to alternate primary care and community-based care would be able to go there. If you would like to contact us, we will get the information back. If you send it, our contact will be at the end. It is, and maybe one of the team can put it in the chat, oht.evaluation@utoronto.ca, and then we can triage to make sure the question goes to the best person to answer the data. Oh, and I see it actually, it is up there as a prior oht.evaluation. So looking forward to, are there other questions? Will the OHTs have the ability to benchmark comparisons within indicators involving change over time? But if you want to compare with other OHTs, so again, you'll be able to kind of go look at other OHT reports. That's one way. But we are creating, and we have a draft. It's not quite ready for public viewing yet, I think. But I'm able, for example, right now to go to a website and click in and choose two OHTs, choose an indicator and a stratification group like primary care model or something, and material deprivation quintiles if I need to, and compare the results of those two teams. So it exists. It is not quite ready for prime time. We should be able to make that available within the next month. We are looking to accelerate data availability. I think also these reports are, I think, as much about providing data as they are about explaining how to use data. So we're doing much more interpretation in these, about thinking about, finding those areas where you are further out on that spider diagram, meaning that there are more OHTs performing better than you. Soon the league table is coming out, the report that we'll have ready within the next couple of weeks. You'll be able to see which OHTs are performing better than you on a given indicator, and then you could look to them to see what they might be doing. Thank you, Leslie. The RISE coaches as testers of the dashboard. That was just into me. Yes, so it's fairly simple, a way that we're going to make this. And I actually had people were already out with some of the data early this year, already using the decks to show how their data was doing and getting questions around, can we use this to compare other HTs, for example, in the north? So this is why we want to make this a little bit more easy to use and available to individuals for that kind of peer. If you are scared of spiders, I'm sorry, Terrence. Well, I would be happy to entertain other opportunities to display consistently, 5 to 10 indicator results intuitively on a slide at one point in time in a single diagram. I'm totally open. Great. Will the OHTs be able to break the data down further? So why don't I go on and talk about some of the stratifications, actually. And we are looking to do more data at a more granular level, such as age or postal code or things. The Ontario Health has a tool online for OHTs that does allow for more granular geographic reporting. as well as some reporting by the CHI Pop Health. The piece, so as a data source, it's really great. What we're hoping to do over the next month is also spend time with the teams talking to you about the data and the ways that you can use it in decision making. So I'm going to go back to a couple of slides here and start talking about some of the ways that we're presenting the data. So one of the big things across the indicators is to look at stratifications. So knowing how your overall OHT is doing, that is interesting. Honestly, possibly not very useful. Without starting to understand, well, in which populations, are there specific areas that we could prioritize in order to help us improve on this indicator? Because, we have a population attributed of 450,000 people, for example, or 200,000 people, or even 35,000 people, and we don't know where to start. So the point of the stratification is to give you some places to understand, either according to what characteristics of clients, so patients, that by material deprivation, their relative socioeconomic status, lots of social determinants of health might play a role here, or also by the type of primary care they have. So OHTs are in their premise, primary centered and based out of primary care. That's how people get attached to an OHT, is through their primary care provider, if they have one. And so that's another way. And then the other two are according to client health needs or client health conditions, I'll say. And we have two of these. So material deprivation, this is the graph on the right shows in each OHT the proportion of the population that live in most deprived neighborhoods versus least deprived neighborhoods. So a low deprivation quintile, the very bright green, that is a relatively wealthy neighborhood, not a lot of deprivation. Those indicators that go into the deprivation index are shown on the left side of this screen. And the places that have the dark blue represents the proportion of the population living in areas that have the highest deprivation. So you actually see quite a bit of variation going from almost 40% of the population in one OHT that is in the most deprived area to that actually being less than 10%. So quite a bit of variation as we look across the Ontario health teams in the material deprivation. And we relate this to the indicator. So in which indicator does this make a difference? It doesn't make a difference in every indicator, but it very much is relevant to some. The other is around primary care enrollment models. Hopefully most of you are familiar with Ontario's primary care enrollment models. Could be family health-based team, or there are several sort of blended capitation models, capitation through family health networks or organizations. And we also put into this group the other grouping, so mostly rural and northern models, because they're capitation but not always team-based care. And then we have other models right through to people not being rostered to a primary care physician. The other ones are around healthcare. So we have whole webinars that we've run on the CHI and the BC Health System Matrix. So we had CHI here to explain back in somewhere around September 2022, I think, to talk about how their grouper is built. And we use the 16 health profile categories, and you'll see what some of those names are. And the other one, because this is very administrative, it's built on healthcare utilization. Another one that we use is the BC Health System Matrix, which is built out of an idea of people encounter the healthcare system with different needs. And it takes sort of, are you trying to stay healthy? Are you getting better? You had an acute condition. Do you have to live over the long term with chronic illnesses and conditions? Which conditions? How complex are they? Or are you, frail, older, and heading towards the end of life, being up at that top kind of area where we think there are the highest needs? So this is another model of looking at your client population. So what our intent is to do all of the indicators according to all 4 stratifications. So you can imagine that amplifies itself quite quickly. And so we wanted to select out those most important 12 indicators out of the whole 27 and show them across all of these, all 4 stratifications to help you understand, is ALC coming mostly in your end of life, or is it mostly from cancer patients, or is it mostly from people with adult major time limited conditions? So you can find out where you need to be thinking about putting in interventions. But in the interest of time today, I am not going to even go through all 12 indicators with all 4 stratifications. Your OHT reports have that in them. And we are posting today the report that has all 12 indicators by all 4 stratifications according to, for each OHT. So that's a lot of data. I'm not going to put all that up today. I'm going to do a little choose your own adventure time today. So I'm going to go through 3 indicators. I have all 12 with me in the deck, but I'm not even going to go through all 12. I think that might not be the most best use of your time when we could possibly have some exchange and discussion about the use of these indicators instead. So could we put up a poll? And my fingers are crossed that we have no errors in this poll. It seemed like on the earlier one, we did have one glitch on having an indicator or one of the response options up twice. So hopefully we did this right. You're going to have to scroll down in order to respond to this poll. Please choose 3. You should be able to choose more than 1. I really hope I did that. Otherwise, if I goof that, then I will ask you just to choose the one that's most important to you. And we're going to leave this up. There's a lot of indicators to scroll through, 12. So I'm going to leave this up maybe for a minute or so. In the meantime, I can pop up over and see what has been coming up over on the chat. So Kimberly asked a fantastic question. The indicators are great, be an opportunity to query data to better understand what is driving the indicator. So we are trying to report things and provide things across all 53 teams in the most recent attributed database. And we are open to hearing from all of the OHTs. And if we can find some common areas, we can support. I would also encourage people to use systems like IDS, to use the online reporting system that the ministry has provided with indicators that allows you to look within some populations and also in geographic areas. In telehealth is an amazing resource to do more diving into specific indicators. And we've seen that example in the past. That does require you have a bit more internal capacity to use in telehealth, for an example. But we are also doing some work now in the background to try and build up routines that OHTs could access in telehealth in order to be able to do and replicate some of this work and dive in. The slides are all available. That'll be posted again. We do see a fair bit, and Wendy, thank you for commenting in and responding to that IDS specific question. In terms of primary care, so we have at this point not added into the use of CHCs or nurse practitioner-led clinics. I think the assignment to CHCs is definitely possible for people receiving care. So as we start to unpack that not rostered group, for those people who are seeing individuals primarily through a community health center or an Aboriginal health access center, we will be adding that in the next iteration of this. We hadn't up till now. So for some OHTs where that's a substantial or even a focus of their population, we're going to fail you. But we are making improvements and we are leading to do a better job of that coming into the future. For now, we're starting to try and engage and see what we could improve about the use of the indicators and making the data more available. We have to pick kind of different priorities of areas that we can work on. And we have some commentary from Catherine Isaacs about the relevance of different indicators, and we'll definitely take that to thank you for that comment. The online report includes all 12 indicators in Shaba by all 4 stratifications. That's being posted as we speak. It'll be available today, and each OHT has received their own results that way. And so the slides that are attached to this deck as well include one example from each of the 12, but like I say, the entire reports and packages to be posted. A correction factor for unattached patients. that would be interesting conversation, Colleen. And I think that's also why, maybe we want to dive into specifically looking at unattached patients, and then maybe even parsing that a little bit apart as to finding out where those individuals are. Maybe that would be an area to sort of overlay primary care model by geography, or one of the other areas as well, to understand a little bit more about that. So we are looking to understand more about CHCs and NPLCs, and maybe they do very well. So appreciate that as an advice. It is an important opportunity for us to be improving on in this work, and looking at other ways of stratifying, such as using a SAMI index. That's a great idea. Okay, we can now, let's go back to the poll, and we can share the results of the poll, and let me see where we landed. So by my view, if I scroll through here, no, it looks like all of the indicators got some response here, which is good that we actually picked indicators that are relevant to at least some of the population. We did try to do it that way. So the responses today say that we should go see about ED visits best managed elsewhere. We should see, let's see, it's pretty close. ALC days is at 35%. I think that is the next one. So we will go stop at ALC. And finally, we have a physician continuity of care, and ED as first contact for mental health are tied at 29. So maybe we have time to hit both of those. Be a little thanks. We'll take this down now, and I am going to go ahead and go to those parts of the slides that are indicate specifically those pieces. Okay, so we had ED visits for conditions best managed elsewhere. I think that is the second slide I have up here. Yes. And here I'm showing you the stratification by primary care model. Again, all four are shown. So as you can see, ED visits best managed elsewhere. This is for all of Ontario. You'll have your own. The overall Ontario average here is 10.1% of ED visits are ones that could be best managed elsewhere. You see here that is actually about at that point for the people who are not rostered. Family health groups, so it's loosely affiliated physicians on some capitation with some after hours care. That actually is the lowest rate of ED visits best managed elsewhere is among that group. And actually we see the highest, maybe counterintuitive, ED visits best managed elsewhere coming out of family health teams. So you might want to have a look within your own results to see, is that true, or which primary care groups? Because it seems that perhaps those people might be having more difficulty getting access, getting in to their team, or they're not as aware of the things that they can go see primary care for. Could be a couple of those different reasons. So again, there's quite a bit of variation. That's threefold variation differences depending on where the individual is receiving care in their primary care group. So a next one was continuity of care. I'm not going to do them in order. I will get to ALC after. So continuity of care, this is the simple way of just saying what proportion of your visits were to the physician you saw most often, almost always a primary care physician. So you see here that it does vary. So people in long-term care who mostly have a designated most responsible physician, 75% of their care is being provided by that individual. People with cancer who have a new diagnosis and are seeing many, many different people through the course of that illness are then actually at the lowest point, which is not terribly surprising. What one would hope is that after they receive cancer care, that they can resume a more normal. So people do not stay in these categories forever. Hopefully they'll come out of the cancer care system and fall back into one of the other lower needs groups where we have slightly higher a continuity of care, but not brilliant. There's quite a bit of work to suggest that continuity of care can be helpful in people to manage their chronic conditions. The way we measure it here is around relationship. There are other aspects of continuity of care, management continuity, information continuity, which is something that sort of came up in our digital health webinar as well as an important aspect to fixate on. So this is just one of these around continuity of care. We can have more discussion. So here's ALC days. This one I've decided to show by the BC Health System Matrix. I've also kind of picked these so you get a flavor of each of the different stratification groups. So here you see that ALC days are, and here you're counting total days across that bottom axis. So all acute days are the dark plus the bright green, and the bright green are the proportion of those days that are ALC. So we see actually a lot of the total ALC days are coming from that high chronic and frail population, which are very often individuals with both multiple complexity from medical as well as social and functional conditions. So I don't think there's a surprise, but there's also a group that are near the end of life. So perhaps the pathway to secure their care outside of ALC might be different than the ones that have other conditions. And then we also see just people with high chronic conditions without considerable frailty are also generating a good number of ALC days in the overall province. So compare your own OHT's results. They will not mirror this. They may be a little bit different. Okay, and the last one we are going to stop on, which was ED visits best managed elsewhere. Oh, that actually ALC days is here also by the POP group methodology, which is a little bit different. You see a little bit less emphasis here in palliative because it requires people to have palliative care as opposed to really being more designated near the end of life. I am looking for ED visits. This is the one, ED visits as a first point of contact. You saw we had 3. So here we're showing it by the Chi-Hi POP group methodology. And so you can see here that if you look at the total numbers of people, some people here were known to have some other related mental health condition in their history. If they didn't have it in the prior year, then they get categorized as an ED because the look back on this indicator is only, actually, I think it's 2 years, whereas our look back in ascribing people into Chi-Hi is a little bit longer. You also see that a lot of the people, in fact, the majority of people are in this minor acute category. So these are people who are encountering in the health system for acute issues. Could be a pneumonia that's primarily ambulatory, could be like a small fracture. Again, minor acute, it'll resolve quickly. Those people are otherwise relatively healthy, and we are missing the fact that they have mental health conditions when they're being managed in the community, and they are ending up in the emergency department with those conditions. So we've got to think about what are some screening opportunities to catch people up front and offer them the navigation to better services. And I know that a good number of OHTs are focused in this area specifically. So that's one of the things, is to find those populations. And there are still people throughout that people have moderate chronic conditions, and they will be in to see their physicians more often, but they're accumulating a smaller proportion. And the people who had no contact at all with the health system, those are going to be difficult for you to find. Those non-users, those are people who the prior year had no contact with the health system, and then they show up in the emergency department. That's going to be a more difficult group to identify in the community, except through some population health initiatives. So that's the little tour through some of these indicators. We had all 12. They will be all available to you. How to use the reports. We have this comes right out of the decks. Have a look at that spider diagram, seeing which indicators your OHT appears to be close to the center. Here you're doing well as compared to other OHTs. There may be opportunities to improve, but you won't be able to easily find that from looking at other OHTs. Using the spider diagrams to see which indicators your OHT appears further to the outside, in that case, you know that many other OHTs are doing better than your OHT. Is that something that's important to you? Because you also have to think about, this is an area for improvement, but is it also a priority for our OHT? Do we have people that are willing and able to actually generate and make a difference that would relate to improving this indicator? So what does this indicator represent? Is that important to us? In which case you can use the provincial report forthcoming to find which other Ontario health teams are ahead of you, and maybe find out either from our webinars, because we do population-specific pieces, through communities of practice will be a great opportunity for you, through the Ontario Health sponsored communities of practice, which are supported by other support groups like the RISE, like Ontario Health, like ourselves, in doing it. And then, thinking about indicators where the Ontario Health teams are most important. You can also look at that second part of the report by primary care model, material deprivation, or health grouping to find out where you have that greatest opportunity for improvement. And those subgroups starting to point you to some of the conditions you need to look at beyond what you've just been doing in the past around improvement. So focusing that activity. You may need additional outreach, for example, in low users or non-rostered patients. That's a different approach if you need to work within a family health team to better access care for that. So that's part of the uses of these. And every Ontario health team has received, someone in your team has received Excel data files with all 27 indicators, their main, stratified by 4 approaches for fiscal years 2021-22 and 22-23. We will be posting all of these by February 15th online. For now, the person that we had as being your most contact. So you can email us. We've caught a few people in the chat, but you can also email oht.evaluation@utoronto.ca for more information. We'll find out who in your OHT received the reports. And we are making a simple online comparator tool to be able to create charts based on the HSPN reported data. So for example, OHT A and B, comparing emergency department visits best managed elsewhere according to a primary care model. And then we still need to go and find out what it is about those 2 OHTs that are different and drive those results. This is data to inform decision-making. This is not decision-making. You have to make those decisions in the Ontario health teams yourselves. So I have, why don't we just kind of go to audience and then we'll come back to the participants so I can get a chance to come down here and look at the chat that's coming in. We are also going to go back to a couple of polls and end off in just a few moments, but just a little bit more opportunities for questions. And Maggie Ford is letting everybody know that the CQIP data has been pre-populated for you in the Navigator tool and is using recent data, the most up-to-date data, and I believe that gets updated every quarter if that's possible. And you see other information coming up there. And we have, so there are, I think that actually responded to Gwen's challenges around some of the data being a little bit old. What I have not yet done is to go back and look at the CQIP data to see how quickly it is changing over time across the Ontario health teams. And I think, I would say that these indicators are all calculated at the total OHT attributed population level. And then when you get into subgroups, you get a little bit more specific, whereas I expect that most initiatives to make a difference and an improvement in these indicators is probably happening at a much smaller level in terms of the number of population. And so I think I recommend that you be looking at ways to capture these indicators at a very local level that you can do in rapid sequence. Probably the best we'll get on having rapid data in the current environment is for hospital and primary care based indicators to be about a quarter behind, running about 3 to 4 months behind. For other indicators, we're going to be further behind. The data flows don't move that quickly yet across the province for everybody. Okay, I am, so Benjamin Hesh pointing out that those people within a family health team also tend to be those who need more care. I think that is an entirely possible option in all cases, and more care for particular conditions, absolutely. It's also the case, I think, that in some areas, family health teams have not actually captured the most complex patient populations, and some of those people are still actually being seen primarily through fee-for-service. So it's a partial answer for sure, but I'm not sure if it's a threefold answer or not. And Nashaba asks about limiting continuity of care to primary care visits. The results, the level changes when we do this, but the importance and how it affects care does not change in the aggregate level. We wouldn't make any different decision or conclusion using a different calculation of the continuity of care. I actually also like another indicator that is called the BICE Continuity of Care Index, which also does two things. Any referral by your primary care physician to another physician gets attributed back to your primary care physician. In fact, it attributes all referrals back to the referring physician, which is, I think, a little bit of a better way of doing it. It's more complicated, but it's better. And the other thing is to account for the number of different physicians, because just by nature, if you have a condition that needs to be managed by two different physicians, then we might want to downplay that and allow you to naturally, your continuity of care is going to decrease as soon as you have some other physician visits. So that accounting for the number of different physicians is as well. So we may bring that, but it's more complicated in terms of its measurement and more difficult to explain. So we get similar results. That's conclusion. Across any of those, we still see the same gradients that we see. We see the same relationships with its impact on avoidable hospitalizations or ambulatory care sensitive hospitalizations. We see the same socioeconomic gradients, regardless of how we measure continuity of care. I have do the indicators, and Holly, I think you had a question earlier on as well about work aligning with the Ontario Health Team performance framework. So I don't think it'd be a secret to say that we are working in collaboration with Ontario Health on setting the framework for the 12 leading OHTs, the advanced ones, which I imagine will have spillovers for all of the Ontario Health teams. So we are very much involved. That is an expert group that is going to select the indicators based on the current set of priorities for the Ontario Health teams. Where those priorities overlap with Ontario Health Team's existing priorities, there will be alignment on these indicators. I think you can count on seeing some things around like recovery outreach, the things that are in CQIP as being part of the signaling of what's important for Ontario Health Teams. Those are likely to, I think, have some overlap, but I can't say anything yet because they haven't been decided. And there's a panel of people who are representing Ontario Health Teams to help select those indicators. We are involved, but we are but one voice, and we're not a voting voice either. So we're just encouraging and supporting that selection. Do the reports include the descriptions of the BC Health System Matrix or provide links? Both. We provide a bit more, and we have an existing technical report that goes through exactly how we get people into the BC Health System Matrix. And the paper that I provided a link to, it should be publicly accessible. If not, we can definitely share it with you. About Bridges to Health tells the story of the meaning, and it's the application of that meaning that led to the BC Health System Matrix. Here's another question around interpreting slides with 1,000-person years. So sometimes when we are producing results, we have to think about what's the best denominator in a consistent way. And so sometimes the rates, for example, I think are, BJ, do you have an example of which one of these we do by 1,000-person years?
Let me take a look.
Well, that's per 100,000-person years. So I have an example. If we look at ACSC, it's per 100,000 person years. So if this really comes from, what would this number look like if we just divided the numerator, like the number of events, divided by the denominator, which is the number of people. So, for example, in the most deprived neighborhood, ACSC hospitalizations are 521 per 100,000. So that would be 0.005 of the population are admitted for an ambulatory care sensitive in the entire attributed population. And so what we do is we say, well, if you had 100,000 people, how many of those people would be admitted? And it's 521 if it's in the lowest area. And then the person years part, so that's persons, is that we put a modifier onto our calculations to account for the fact that someone is not at risk after they die. So we only count the people while they were alive into that indicator. So that's kind of a little bit of a technical piece, but you'll see mostly it's for scaling and interpretability. and something like ambulatory care sensitive conditions, premature mortality. These are things that are slightly more rare events. We put them on those scales that you can interpret them out correctly. I don't see other chat, but I'm happy to answer other chat questions that come up. If they do, I might have missed one or two across early on. I don't know, BJ or others on the team, if you've seen things that were important. I see, and this is a total random scaling back. Colleen Lackey asked a question about ambulatory care sensitive hospitalizations showing up in clinical condition categories. Yes, we don't have a definition that explicitly pulls out people with heart failure or with COPD. I think that would be very useful, particularly for the teams that are focused on heart failure and COPD. In fact, we do have a bit of a question out there of which other conditions. We've done a diabetes specific report, but are there other conditions that we could start to look at more specifically to support Ontario Health teams? And if so, using what indicators? Remember, our aim here is to be focused on improvement indicators. So what are those areas to improve in? And if that can be done within a certain group, perhaps it actually is the existing set of indicators that would be useful to see within a particular population as well. And thanks, Mike, for chiming in a couple of times with suggestions and some links there I see to the primary care reports. And I saw you responded into a couple others. I'm talking a lot today, so it's a little bit more difficult for me to keep up to the live chat at the same time. So appreciate COPD, CHF, COPD, and the integrated care pathway. So that being those two and possibly some others as well. I think that's going to bring me to come back and I think come back and put up another poll for folks. And this is actually one for now and another to help guide our work looking forward. So here's the first one, which is, was this a good use of your time? So how knowledgeable are you about the HSPN reports on OHT improvement indicators? I hope nobody's going to score a 1, which is you have no idea. And I also am not too sure anyone's going to be scoring a 10 of knowing exactly what to do. I hope there is someone out there that is that. But I want to kind of get a little bit of a sense of where people are at, and it also how it kind of helps to gauge both our work and other supports work here if we have a bit of a sense of how people are doing. So please, irrespective of whether you are actually needing to use this for an OHT or not, I'd like to try and get a pretty high response rate here. We still have over 200 people online, even past the hour. So I know that this has been a useful webinar. Otherwise, you wouldn't be here anymore. Okay, so still some people chiming in about your awareness, how knowledgeable you might be on OHT improvement indicators. And so we've gotten about halfway there. We can share these results back. I mean, past halfway on the response rates, but halfway, I think, on how we did and how knowledgeable people are. So people are somewhat knowledgeable, 40%, and a couple a little bit higher than that, but also a few a little lower. So we very much look forward. I'm glad you've had this introduction, and this will be available online, the posted video, to people who in your OHT should know about these indicators. And I'll say we're coming out in February. Watch for emails. They could come from HSPN, but they will also be coming from some of the RISE coaches and OHT fellows, impact fellows that are out supporting Ontario Health teams. It's a team effort. Otherwise, we'll still be doing these in June. But in order to get out quickly, we need a large team of people who are mostly schooled in having done this previously. So I look forward to that. Okay, we can take this poll down and let's go on with the next. So HSPN is always looking to evolve our measurement and reporting. This work looks a lot different than it did 3 years ago. And we are very much looking forward to continuing to evolve in our work. So here are some of the ways that we thought, and what I'm most interested in is the last option, which is other ideas in the chat. But, can we help you interpret the indicators to prioritize areas for work? Taking on additional analyses and reporting on the existing set of indicators. So what can we do related to that? And how much of our effort should be focused on changing the indicators that were reported on as opposed to using the set that we've been using over time. So tell us what you think, and please, any other ideas? I'm looking forward to that chat lighting up. We are also going to be coming out in a few months after we've done the coaching and you've had a chance to sit on this a little bit, and we'll be doing a few interviews. We might run a quick survey about the usefulness of these reports to your teams. And again, trying to get feedback to improve. A little bit to the chagrin of my team, I say, if we're doing the same thing in 3 years, we haven't learned anything. So as much as we're trying to help you learn, we're trying to learn ourselves how to do this better. Okay, I think we could share out these results. A few people start responding back in. So using the existing indicators to prioritize areas from work, that's the top one. And so we will look to help with that. Creating additional analyses. Look forward to reading a little bit about what some of those ideas might be. Changing indicators, some people said we should be thinking about. So we are looking to evolve new data sets, and we'll look to have more of that. And then finally, ideas into the chat, which is now coming alive. So thank you very much. Looking forward to the meetings for a deeper dive. Look forward to those too. More reports to drive deeper into different priority populations. And so doing that in a systematic way. Thanks, Leslie, for that great advice. And we can learn from how OHTs themselves are doing this too. Some OHTs have the capabilities and learning and creating. So bring those ideas to also our community of practice, which are co-led by Kaylee and Priyanka from our team. So that would be a great opportunity for us. More patient family perspectives with data. Dean Valentine, thank you very much for that comment. And bringing in more patient experience. We haven't shown these indicators. We have a number of OHTs that are using the patient experience survey that we've created at scale, and a number that have used it in minor ways. So having more patient reflections on through PREMs and PROMs on OHTs is really important. And I know we're doing this on Ontario Health Teams, also part of, we just sent off data to the OECD based on a pan-Canadian study of PROMs and PREM measurement. So trying to make sure that we actually start, it's going to be the first OECD report that compares 20 health systems based on what patients think of their care, which I think is an amazing step forward in understanding how well our health system is doing. A couple of the other chat points here, having a comparator model is important, and case studies of entire process, starting with the data, segmenting, drilling for analysis, diving deep, and assessing impact. Thank you, James. We might follow up with you about how we could land on those. Continuing to align data with OH priorities. So the leading projects, heart failure, COPD, absolutely. And also collaborating. So one of the things we've been saying to our team, we're putting out these indicators. This time around, we're doing a little bit more of explanation for what they mean and spending more time on that. And I think, to your point, Colleen, around change ideas. So Ontario Health has supported the CQIP indicators, some change ideas. We are looking in our years out to do more of that work where it doesn't already exist. We'll take it on ourselves. And so we'll be doing a little bit more of that. Equity to overlay the interpretation of existing numbers. So Diane, thank you very much. You can look at that one way through material deprivation. All of our indicators, everything we've produced, can also be seen through the lens of material deprivation. We also, we've produced these league reports, but I'm looking at some data. Jessica Morgan's been on this webinar a couple of times, and she'll be on again in March, who is a student here at the University of Toronto studying how to report on performance, how to report on health equity in health system performance specifically. And so I've got data now that actually look at the OHTs from Jessica on ambulatory care sensitive hospitalizations and according to how inequitable that distribution is across OHTs. So count on seeing new ways of looking at, visualizing, and interpreting data, health related to equity specifically. We have, I think, We have some related to frail older adults, I think is mostly defined by cognitive status through dementia. I'll come back to that. But I think a lot of, if you were to look into the subpopulations, for example, the BC health system matrix in the frail older population, I believe frailty is primarily defined by dementia. So you'll get a lot of those people have dementia. I think that's a great and important idea. I wasn't aware that January was Alzheimer's month. Thank you for bringing that to our attention. I did notice the other day that January is cervical cancer awareness month. So we have a few things on the ball, and I think February is mental health awareness month, if I recall correctly. So definitely ways to generate opportunities. So a lot of resistance to using ED as first contact, looking for indicators of more meaningful as a system for the mental health conditions. I do not have any official position when I say I have to somewhat agree with you, Angela Freeman. That's a very difficult indicator to manage. That was entirely personal opinion. Do not represent any organizations in saying so. Other ideas, yes. So thank you very much. Appreciate those ideas that you're popping in there. We should share with you a couple upcoming pieces that I think you will find good to know. We get together every fourth Tuesday of the month. Couldn't amount to a better time. And upcoming in February, we have very, very interesting work on policy supports for integrated care. So how do we generate support to groups like Ontario Health Teams? So we have done a bunch of interviews, about 20 or so interviews in Ontario with Ontario Health Teams and what supports they think they need or are getting. And Ontario Health and the Ministry for the supports that from a policy perspective, they think are important for OHTs and what they're doing. And then we went and we said, other people are trying integrated care around the world. What do they do? So we looked at the United States, Germany, England, and the Netherlands, being 4 countries that have advanced integrated care models in various aspects. And so we have results from those countries and our case studies of them. And we collaborated with the North American Observatory for doing that work, and they'll be on, along with a few international representatives to help interpret. That's February. In March, equity in the Ontario Health System. We've been working on 5 reports, mostly by our trainee group. Certainly I've seen all of them, and there's some amazing work, right from collecting frontline data to using it to programs that have done changes. And if you've been watching our webinars, there were 4 in the past year. You will have seen little highlights about what some of these are. Access to diabetes care, how do we measure health system performance? I mentioned some of that work just a moment ago. So that's going to be March. And that actually comes to the close of this term of HSPN. We have applied for a new funding from the Ministry of Health that we are very hopeful for to generate a new iteration come April. So we've got a lot of feedback in the chat along the way, but we do like having the opportunity to reflect on this. So here's the QR code. We also post in the chat the link that you can use to go in and let us know how we did today. Really appreciate your having taken time out of your days. I know you have a lot of meetings and you actually run the health system. Not like me. I just kind of sit here and look and try and provide some useful information about how the health system's running. You know, it is not the best information, but it is consistent information. It is comparable information. And in many cases, I think it is at least a signal. So you've got that. If you're able to provide feedback, if you need to contact us, you can do so. We said related to these projects, oht.evaluation@utoronto.ca, but you can contact us anytime at hspn@utoronto.ca as well. Follow us on YouTube. Watch for this video. You share it around once you see the link that it's available. And I thank everybody for participating today. And I wish you all a wonderful afternoon. Take care. Good day.